this program with short introductions. It's going to be a series of introductions, not all the introductions at one time. I will start the first introduction with our guest of honor, Professor Norberto de Vega, who's one of our living legends in cardiac surgery, who introduced the tricuspid annuloplasty for treatment of tricuspid regurg, which bears his name, de Vega plasty. Everybody knows at least the name, and now you see him in person today. I'm very grateful for him to accept our invitation, and to make things simplify things for him, I'm just going to ask him 2 questions so that the global audience, as well as our colleagues, will know what was the idea behind this de Vega annuloplasty. So please, Norberto, my good friend, try to explain how you came to that idea to do the tricuspid annuloplasty. Some of us in this building here. Please, Norberto, are you around? He's lost. Yeah. He's not connected. He's disconnected. Okay. Then we will continue with a further introduction. My good friend, Professor Manuel Antunes, very good friend, who's going to also moderate this first session with me. He's also one of the famous cardiac surgeons in rheumatic mitral valve disease. He has gone to so many missions to Africa, especially to Mozambique. And he's also a promoter for modifying the de Vega plasty, which makes this technique more solid and also more durable. And I'll be very pleased to welcome you, and Manuel, for accepting my invitation. I would like to now invite Professor Francis Smith. Is he connected?
Yes, I am. Thank you.
Yes. I would like to invite you to start your talk so that we don't waste time. Your first talk of the session is going to be about the cardiothoracic training in Africa.
So can I just confirm that you can see that?
Yes, excellent.
So I think that today I'd just like to address you on the development of a multi-center integrated interdisciplinary simulation program based in Africa. And I don't want to spend too much time, but I just want to remind you briefly that Africa is a continent that's home to 1.4 billion people, up to 1 billion living in sub-Saharan Africa. As you know, and we've reiterated this over many times, that the community is greatly underserved, the units are underfunded, a limited resource environment. There are competing priorities between communicable and non-communicable disease. And there's also certainly a contribution, a lack of political will and clear.
Francis, your slides are not running. Your slides are not running.
I think
is that,
here, you have the problem with the privacy settings. You have a Mac also.
yes.
You have to go to the privacy settings and tell that the live, what's the name of this thing? The live size can share.
Okay, fine. Okay, but then I suggest, I suppose, Charles, you should go on with someone else.
I think you share the wrong screen.
You're in the wrong screen. Then the YouTube the blockade then, yeah.
Okay.
You didn't. Weitermachen mit anderen. Ja. Okay, not to waste time, shall we go on to the next talk from Manuel? Are you ready to give your talk?
Yes, I'm ready.
Yes, okay. Then please start more or less the major topic actually of the program. Is going to be presented by Professor.
Can you see my screen?
Yes, try.
Can you see it?
Yes.
Okay. Well, this is the title that that Professor Yankah gave me to speak on. But before I go to that, I just want to give him again a warm congratulations for his 80th birthday. That is the main reason why we are here. Of course, I also want to salute everybody who is with us this afternoon and say that there's been too long a time we don't see each other personally. I hope that comes back soon. Okay, I was then asked to talk about tricuspid annuloplasty for moderate TR. That means less than severe, because for severe, we all know what to do in young patients with rheumatic mitral valve surgery. Should we do it? Should we not do it? To whom and when? I just start to say that I have no conflicts of interest with this talk. Well, if we can summarize the patient characteristics, it's young patients, poor, generally speaking, uninstructed, with difficult access to medical care, which means second chance is almost never there, poor compliance to prophylaxis and therapy, be it, for example, penicillin for prophylaxis of rheumatic fever. Now, we're talking about just acquired tricuspid regurgitation. So I exclude primary, that means organic, which is present in about 8 to 10% of the cases, often with rheumatic cases because the tricuspid valve is also affected by the rheumatic process. So we'll be talking essentially about secondary, what used to be called functional tricuspid regurgitation, 90% of the cases, usually accompanied by pulmonary hypertension and left-sided valve disease. Now, the incidence of this condition is variable depending on the reports, 80%, 35%, more recent report, 20 to 30% depending on the definition. And in 80% of these cases, the TR is functional. And only it's organic in only 15 to 20% of the cases. Now, in the past, we were mostly influenced by these paper published some 50 years ago, more than 50 years ago, by Nina Braunwald, who said that in the majority of cases, with secondary TR, surgical treatment of the mitral or aortic disease corrects the problems of the right side. That means forget the tricuspid valve. Now, we today know that the tricuspid valve is attached to the right ventricle and is influenced by the function of the right ventricle, which by its own is influenced by the performance of the left ventricle. It's like a sidecar, side by side. In fact, the results of surgery of the mitral valve are less favorable in patients with associated right heart disease. The right ventricular disease with significant involvement of the tricuspid valve represents advanced disease with a decisive effect on the natural history and evolution after surgery. And even when the mitral valve surgery has long-term success, in many cases there is a progressive increase of tricuspid regurgitation if it was not involved in the initial surgery. So the question is when to intervene. Some 15 years ago, 17 years ago now, Jill Dreyfus came up with this paper that became sort of a Bible for treatment of tricuspid regurgitation. Secondary tricuspid regurgitation or dilatation. What should be the criteria for surgical repair? You all know this scheme. The tricuspid valve was measured in their experience, and even in the absence of tricuspid regurgitation, there will be secondary dilatation in a significant number of patients with severe mitral regurgitation. So they concluded that tricuspid annuloplasty at the time of mitral valve surgery in this patient resulted in improved functional capacity without any increase in perioperative morbidity and mortality. This was a revolution because it was not talking about tricuspid regurgitation. It's not moderate tricuspid regurgitation, was less than mitral regurgitation, sometimes absence of tricuspid regurgitation. But this wasn't really new. I worked for 14 years with Professor John Barlow, and he said in his book published in 1987, so some 18 years before that paper, that it is probable that this lesion, tricuspid regurgitation in rheumatic fever, is often partly or mainly organic. That means involvement of the tricuspid valve, direct involvement. And he claimed, and he really tried to influence me to do prophylactic annuloplasty, even if there wasn't significant tricuspid regurgitation. I had the fortune of sharing with him his last paper before he died more than a decade ago in this management of tricuspid valve regurgitation. Now, after the paper, several teams, including Dion's team in the Netherlands at that time, concluded that concomitant tricuspid annuloplasty during mitral valve repair should be considered in patients with tricuspid annular dilatation despite the absence of important tricuspid regurgitation, because this improves echocardiographic performance. Also, this group, Calafiore from Italy, said that an aggressive strategy of functional tricuspid regurgitation correction using the systolic tricuspid annular diameter was able to reduce the tricuspid regurgitation grade 1 year after surgery, but mitral valve surgery alone could not. So do it, don't leave it alone. Following on those papers, Jill Dreyfus and other papers, the guidelines started to indicate that surgery, of course, is indicated in all patients with severe isolated primary tricuspid regurgitation and also secondary tricuspid regurgitation. But more important, it came with this clause saying that surgery should be considered in patients with mild or moderate secondary tricuspid regurgitation with dilated annulus. That means more than 14 millimeters in diameter or 21 millimeters per meter square, undergoing left-sided valve surgery. The guidelines on the other side of the Atlantic, those were the European guidelines, are more or less in the same tune, with a little difference because with this regards, the American guidelines also gave a type 2A indication, but only when there was progressive RV dilatation or prior right heart failure. It wasn't just enough to have figures above those considered in the European guidelines. The problem is that individuals are very variable, the size of individuals, and there is a great variability of tricuspid annular diameter in healthy persons. And you can see the absolute figures and the index figures by the body surface area, and you can see that you can have a tricuspid valve area greater than 22.8 millimeters per meter square and still be normal. More recent papers have come again with some answers about this question. This paper coming from Salvador, Brazil, in patients with rheumatic heart disease undergoing cardiac surgery for rheumatic mitral valve disease, performed tricuspid annuloplasty in individuals who had moderate to severe tricuspid insufficiency was not associated with increased surgical mortality. So you are there, it does not increase mortality, it takes 10 or 15 minutes to do it. In this paper coming from Israel, from Tel Aviv, in 147 patients with a mean follow-up of almost 11 years, the conclusion was that this study demonstrates good long-term results in patients with rheumatic heart disease undergoing mitral valve replacement with concomitant tricuspid valve annuloplasty. And this other paper shows that concomitant tricuspid annuloplasty could improve RV remodeling and function. So even the right ventricle could improve if the tricuspid valve regurgitation was treated. Now, the European Heart Association and the European Society of Cardiology had this working group on valvular heart disease, which created this position statement. I led the task force, which recommended that, tricuspid valve surgery for a class 2 indication, 2A indication, should be operated on, that means an annuloplasty, when there was mild to moderate TR and there was recent signs of right heart failure, and or the tricuspid annulus was larger than 40 millimeters. So how to intervene? There are some remaining controversies about tricuspid valve surgery. The first one is the choice between annuloplasty and the replacement. We'll talk more about that. The efficacy of different methods of annuloplasty and choice of prosthesis should we go for valve replacement. Now, in my view, only exceptionally will the tricuspid valve need to be replaced as a first procedure in these situations when you treat left heart valve disease, especially the mitral valve, because the valve, the tricuspid valve, tolerates well a less than perfect repair. So annuloplasty is the surgery of choice. And there are three types, gross types, there are more types, but big cuspidization, the De Vega, and I want to especially salute to Dr. Norberto De Vega, a good friend, for being in here. Thank you very much for your friendship. And the use of rigid rings or flexible, rigid or flexible rings. The K procedure, the big cuspidization, what did was cancelling the posterior part, the posterior leaflet of the tricuspid valve. So the procedure was limited to this external part of the tricuspid valve. Simple and with good results. This paper came some 15 years ago from Larry Cohn's unit. They compared 237 patients. Some who had 157 had ring annuloplasty, had the big hospitalization, and 80 who had ring annuloplasty. And they come up with the conclusion that patients who had the big hospitalization survived better, were more free from moderate 2+ TR at long-term follow-up, at least mid-term follow-up. Now, the French group from Paris had a long time ago demonstrated that 5/6 of the dilatation occurred in the mural portion of the annulus of the tricuspid valve. Hence, they came up with the famous tricuspid Carpentier rigid ring, which has this format in the original version, which gave good results. And more or less at the same time, Dr. De Vega came with his famous De Vega annuloplasty, which consisted on a double suture, again going around the whole portion of the mural annulus of the tricuspid valve. Easy, and that's the way I started working on the tricuspid valve. Now, there are several papers who compare the rings and the annuloplasty sutures. In this case, for example, from Spain, 299 consecutive patients underwent surgical tricuspid valve, repair of the tricuspid valve. A prosthetic ring was used in 78 patients, a commissurotomy and the ring annuloplasty in 82, and isolated and suture annuloplasty in 105. And they concluded that there were better results with conventional De Vega suture annuloplasty compared with rings. But there are others who come up with a different conclusion. For example, in this group from Canada, Terence David's group, placement of an annuloplasty ring in patients undergoing tricuspid valve repair is associated with improved survival and event-free survival. This paper, which is a meta-analysis, found several papers, and one cohort study with 129 patients concluded that ring annuloplasty had the lowest rate of recurrence compared with the Vega. In contrast, they reviewed one recent study, and for all the studies who found no significant difference between the two techniques, and they reviewed one study that reported the Vegas as superior technique to the ring annuloplasty. I showed you the paper early on. The other question is that when you use the ring, you have to be aware of the essence of the implantation of the annuloplasty rings. Let's go back to the Vega annuloplasty. The only problem that was associated with it, technical problem, was this guitar string syndrome, which is the tearing of the insertion of the sutures in the annulus, as you can see. And for that reason, in 1987, I and Dr. Girdwood, then in Johannesburg, South Africa, modified the technique by just implanting Teflon plates for each penetration of the annulus by the needle. And with that, we completely avoided, it completely disappeared from our experience, the guitar string syndrome. I have personally used it in more than 1,200 patients, with less than 1% reoperations until now. It is fast, technically simple and cheap, and prevents the common cause of failure of the De Vega procedure, which is the tearing of the suture from the tissues, leading to recurrence of tricuspid insufficiency. You can see here a patient who was the art from a patient who was submitted to transplantation, and see what, in my view, is the one problem of this suture. This is our own, one of my colleagues' technique. You can see how well integrated the plates are, but this was not completed. We have come to the conclusion that if you want to have a good result, you have to extend it to the mid portion of the septal leaflet of the tricuspid annulus, the same as with the rigid Carpentier ring, which has exactly this shape. So the implantation of a ring, in my view, is specifically indicated when there is organic involvement of the tricuspid valve, usually with stenosis, where commissurotomy is also necessary. So in conclusion, secondary tricuspid dilatation is present in a significant number of patients with severe mitral regurgitation without tricuspid regurgitation. It is a progressive disease which does not resolve with correction of the primary lesion alone. Hence, tricuspid annuloplasty at the time of mitral valve surgery results in improved functional capacity without any increase in perioperative morbidity or mortality. Thank you very much for your attention.
For the excellent full of experience, full of
you know, I had a problem.
and, sorry,
I'm waiting for you as long as you can, as long as you want.
we work on it. We are going to work on it. No problem. No problem. thank you very much for this important information you gave. The data, it's actually more data for our discussion during the panel discussion. Just one question so that you don't go just dry. Is it possible that because you said the Vega annuloplasty can be used almost in all the functional tricuspid repair, unless it is organic. Do you conclude that the Vega plasty has still a role in the modern cardiac tricuspid surgery?
Yeah, first one clarifying question. If you see my operation reports that I give to the patient, it's always reported as a modified Vega procedure. It's never given any other name. It's a knowledge to the person who thought about the concept. The concept is the same, the technique has been slightly altered. And yes, it can be used in all patients. I only use the tricuspid ring, the Carpentier ring, which I use in all my mitral repairs, when there is organic disease. That means especially if I have to do commissurotomies, because there are fusions of the commissures of the tricuspid valve, or in cases where you need to do more extensive repair, for example, if the tricuspid valve is involved by endocarditis. Otherwise, I use it routinely for treatment of tricuspid regurgitation.
Right. Well, I've reviewed for the last few weeks, a lot of articles on this annuloplasty rings versus suture annuloplasty. And what I realized that the problem lies in the impact and also the protective characteristics of the annuloplasty rings. If there is an annular dilatation associated with leaflet tethering, because the leaflet tethering worsens the annular dilatation. And I see that the annuloplasty ring, the flexible, the reed, serves as a shock absorber, so that it reduces the ring dilatation, and at the same time protect the ring, the leaflet, from being displaced when you have left ventricular dysfunction and septal dysfunction, which then, of course, creates the leaflet tethering. Have you experienced such a phenomenon or pathophysiological?
No, I don't see how the ring protects it from tethering, because tethering is the tension on the corti tendinei, which are in the edge of the leaflet. So the ring doesn't have anything to do that. But then you're right. Here is a situation, if you have severe RV dysfunction and severe dilatation, those patients are on the way to transplantation when it is available to them. But then if not, that's probably a reason to do a tricuspid valve replacement. It's the only way that I can see that you abolish completely the tethering, is if you replace the valve.
Right. Okay. I won't go on further because we have some few topics we can discuss during the panel discussion. And now we have to come back to our session. And I see Professor Lord Boating. Hello. Right Honorable Lord Boating has just connected successfully. And I would like to introduce Lord Boating as a barrister at law who first rose to prominence as a campaigning civil liberties lawyer in London, Great Britain, has a long and distinguished political career as Member of Parliament for Brent South, 1987 to 2005. His first job in government in UK was 1997 as Parliamentary Undersecretary in the Department of Health, holding many ministerial positions. Was Britain's first black cabinet minister in 2001, including Minister of State, Home Office, and the Chief Secretary to the Treasury. Now he served as a high commissioner to South Africa between 2005 and 2009, and was introduced to the House of Lords in 2010. And he became Chancellor of the University of Greenwich with the effect from 1st of 2019. Now, Lord Waddy, my old friend, I would like to give you the floor to give your laudatio.
Thank you very much indeed, Professor Yankah. I feel I must say, dear friends, something of an interloper. I am not a distinguished clinician. I am not a professor. I do not have anything to add to the discipline which brings you all together today. But there is another reason why we are all here. And that is it not, dear friends, to celebrate a life, a great life, the life of Professor Dr. Charles Yankah. We are here to celebrate that life, 80 long years of it, because we, all of us, owe you, Professor Yankah, a debt of gratitude. We owe you a debt of gratitude for your contribution, undoubtedly, to the discipline of cardiology. And anyone listening in to this symposium, this colloquium today, would get a sense of the depth and the width, the range of expertise that is assembled under your leadership, that is assembled to celebrate your life and your contribution to cardiology. We are also here, of course, to celebrate someone who is a proud son of Africa, of Ghana, but also, and importantly, has managed to build a vital bridge between Europe, Africa, and the wider world around his discipline. And a particularly important relationship, the relationship between Germany and Africa. A relationship, I'm bound to say, Professor, that is all too often overlooked in terms of its significance. But certainly, for those who, like myself, are of Ghanaian heritage, those of us who were brought up as I was for the greater part of my childhood in Ghana and in West Africa, we know that actually the relationship between Germany and Africa is a significant one. It is one all too often overlooked because of the intervening events of two global wars and all that led up to them. But for many still in Africa within living memory, that role has been an important contributory factor in their lives. In my own family's case, my paternal grandfather never spoke a word of English, but as it happened, he did speak and understand German. Why was that? It was because his father, my great-great-grandfather from Achim Tafo in the eastern region of Ghana, had had the foresight to send his eldest child to be educated by the Basel missionaries in what was then German Togoland, just a few hundred, well, less than 200 miles away from my father's village. So he spoke German. He owed his education to German speakers. And Professor Yankah, you have devoted the greater part of your life to promoting the productive relationship between Germany and Africa. You have made a huge contribution to the strengthening of that relationship. Also, and importantly, a contribution to capacity building between Germany and Africa, not least during your time as an advisor to Chancellor Merkel and to the German government. We owe you a debt of gratitude for that. Also, and importantly, we owe you a debt of gratitude for all that is being done by cardiology to the delivery of SDG 3, the SDG around good health and well-being, the SDG that sometimes we forget makes an important contribution to building the capacity of Africa to deal with non-communicable diseases. And as a result of that, your work in Africa and in building the relationship between Europe, Germany in particular, and Africa has led to huge improvements in the life and well-being of countless numbers of people in Africa as a result of your contribution to capacity building and education and the delivery of heart services on the continent. We know that your work in cardiovascular research, your work in developing Africa's cardiovascular health system has been hugely important. And for that, we want to say much thanks. We also, and importantly, Charles, and I end on this, want to recognize your own personal qualities of warmth, of openness, of accessibility to ideas and to people. And your gift of communication, your gift of teaching, yes, but your gift of friendship. So for all of that, Professor Yankah, my dear Charles, we want to say thank you, thank you, thank you, and happy birthday. Happy birthday, dear Professor Yankah. Happy birthday.
Thank you, Lord Martin. Thank you, Lord Martin, for this wonderful laudatio, and it will keep us in mind forever, and we will never forget you for having such a laudatio day, the 19th of April, which of course my birthday was last Friday, on the 15th of April, but it's not far away from there. Thank you very much, and I would like to continue the session by completing the surgical aspects of the program that we started by inviting Dr. Bettina Fanmüller to give her talk on the possibilities for performing mitral and concomitant tricuspid valve surgery using the minimally invasive surgical technique.
Very much. I hope you can hear me. Thank you very much for the introduction, and my special congratulations to you, Professor Yankah, also. I wish you the best for your health. Good luck, everything good. It's fascinating to hear what you have initiated in all the years. Now I try to share my slides. Do you see it?
Not yet.
Not yet. Now perhaps you can see it.
Not yet. Yes. Yes.
Yeah. Okay. So the topic of my call is minimally invasive cardiac surgery, concomitant mitral valve repair, and tricuspid annuloplasty. I will speak about some topics about the setup for minimally invasive mitral and tricuspid valve surgery, about the limitations, about the indications for concomitant tricuspid valve surgery, and we have heard something about from Manuel Antunes, and something about the techniques which are used for concomitant tricuspid valve surgery. In our cases, in Leipzig, we operate usually patients with degenerative mitral valve failure or patients with functional mitral and tricuspid valve insufficiency, not so often rheumatic valves. What's the setup for minimally invasive mitral and tricuspid valve surgery? Here you can see a typical setup. The cannulation for the pump is from the femoral artery and vein, and for the tricuspid valve surgery we need additionally a cannulation of the jugular vein, which is done from the anesthetic. Here you can see the anterolateral mini thoracotomy with the incision. Here you can see the retractor to lift the left atrium. Here is the camera. Here the aortic clamp, and here you can see the vent for the left atrium. The cannulation is something special, and it's very important for the minimally invasive technique. Here you can see the Seldinger technique and test that the wire is in the right atrium, and here is introduced a very long cannula into the right atrium and the upper vena cava, and this is tested again by echocardiography. The next step is to cannulate the artery, the femoral artery, and then you can start the pump. At this moment, you can stop the ventilation, and then we perform the incision, the anterolateral mini thoracotomy. In the fourth intercostal space, usually the first things are to place the port for the camera, and the camera itself. This is the view of the camera, and you can see here the right atrium, the cardioplegia cannula, the aortic clamp. You have to use the bulldog clamps for the upper and the lower vena cava, and here you can see the incision of the left atrium. This, remember please, if you can see now the next slides, the video. Here you can see the lung and the pericardium. The heart is empty and ventilation is stopped. it's very important that the heart is empty for the retrograde cannulation of the femoral artery and vein. Then is introduced the cardioplegia. The next step is to clamp the aorta here. And here you have a suture to show the distance, the groove between the right and the left atrium. Here's the pulmonary vein. And the left atrium is opened. These are the steps for the left atrium for the mitral valve repair. Our topic is now what was a tricuspid valve repair. Unfortunately, it's not possible to show a video. It doesn't run at the moment, but I will show again the next point. Here you can see the points you can introduce the bulldogs in the upper and the lower vena cava. And then you can cut the right atrium as you always do with sternotomy. It's nothing special, it's the same as you always use in sternotomy. Another point is if you want to operate a patient, for example, as reoperation, and you have to perform an isolated tricuspid valve repair, you can also introduce Fogarty catheters and operate in beating heart. And the results of this operation are very good. We had elective surgery of these patients, and no of these patients died after surgery. Here you can see the placement of the Fogarty catheter, but I see the medium is not found at the moment. What are the limitations for minimally invasive surgery? These are some points. The diameter of the aorta ascendens shouldn't be greater than 40 millimeters. You have seen the placement of the cardioplegia cannula, and sometimes if the aorta is very big, there's the possibility of dissection, and due to that we only operate patients with smaller than 40 millimeter with the technique, minimally invasive. Aortic valve regurgitation shouldn't be more than 2. It's not possible to give cardioplegia in a very good case in this patients, and due to that we used to operate these patients with sternotomy, and we have a better control of the cardioplegia. Another point are massive adhesions of the right pleura. This is sometimes a problem in patients who had infections or who had reoperations, and you can destroy the lung and have much problems more than to perform a median sternotomy. High diaphragm is a very big problem because you can't see the heart very well. You can place the diaphragm a little bit down, but not too much. And another point is a big distance between the skin and the mitral or tricuspid valve in patients with adipositas. You can have a look before the operation whether the instruments are long enough. All other patients are operated well with the technique mini thoracotomy. What are the indications for concomitant tricuspid valve surgery? It's the same as we have heard in the call from Manuel Antunes. The part of the posterior leaflet dilates in the patients with tricuspid annular dilatation, but mostly not the anterior and the septal leaflet. And another point is that the ventricle can dilate, and so we have sometimes also a tethering of the tricuspid valve. We have seen that the patients after mitral valve replacement, in this case rheumatic patients with tricuspid regurgitation, had not the possibility that the tricuspid regurgitation improved or disappeared after mitral replacement. We have thought that, but 20 years after, we saw that many patients come back for operation with tricuspid regurgitation. Another point was the publication by Nat, and we saw that patients with the severe tricuspid regurgitation, but sometimes asymptomatic, reduce the life expectancy. What's now? 2017 was published a manuscript, and we have seen that the tricuspid valve surgery goes up in the last years. And we have seen also that the mortality of the patients was always the same. The problem is that the patients with, in this case, isolated tricuspid valve surgery come very late for the operation. And in the last years, the indication for tricuspid valve surgery, and especially for concomitant tricuspid valve surgery, was better and better. And we see now that patients with mitral valve regurgitation and tricuspid valve regurgitation get tricuspid valve surgery, not only if there's a tricuspid regurgitation grade 3, but only if there's a dilated tricuspid annulus. What do we do with the type 1, the annulus dilatation? The K procedure, you have seen it, the Yankah, the modified Yankah, or the rings. But what is the best of the techniques? We ourselves showed at our collective, and we saw that patients with the flexible bands had no tears in the septal part of the annulus, and we decided to use flexible bands in Leipzig. If you have a look to the results with the different techniques, you can see that the flexible rings and the rigid rings have different outcomes, and also the Yankah and the K procedures. Here you can see the rigid rings had the best results, and not so good the flexible ring or the suture techniques. But why? The flexible ring is nothing else than the rigid ring. The Cosgrove band, for example, doesn't dilate. Why do the patients get additionally and tricuspid regurgitation after some years? Here you can see also the techniques, and we have to say the rigid ring is the most standardized technique for tricuspid regurgitation. The one problem is what's with the sizing. If you do a de Vega or a modified de Vega, how much do you reduce the annulus? And the other point is, how much do you go around the annulus? We have seen it in the slides before, and I think this is a big point, to go around the commissure from the posterior and the septal leaflet, because we know the dilatation is in this region. And if you do a de Vega or modified de Vega, or if you implant a flexible band, you're always free to perform. And with the rigid ring, you have always a place where the ring ends. And I think this is one of the points that makes the difference between the techniques and the results after some years. What is with the type 3B, with the tethering? The possibilities of repair aren't the best if the tethering is more than 1 centimeter. But you can perform the Clover technique, and this is the same which is used now in the transcatheter techniques. Or you can implant a patch in the anterior leaflet to give the tricuspid valve more valve size. Here you can see the implantation of a ring in a patient with tricuspid regurgitation due to annulus dilatation, performed beating heart. And this is after implantation of the ring. Here you have also a pacemaker through the tricuspid valve. That is usually sometimes the case. And this is another point for discussion. Leave it or leave it not. But it's a wonderful technique with a minimally invasive mitral valve and tricuspid valve repair. The patients can leave the clinic after 5 to 7 days, and they have really a very small incision. Thank you very much.
Excellent overview of your technique, the minimally invasive technique approach to correct tricuspid valve regurg. Just 1 or 2 questions from the floor, because we want to reserve some of the questions for the panel discussion. No question? Okay, then I'll ask 1 question regarding the rigid, semi-rigid, or de Vega suturoplasty. If you compare the modified de Vega plasty from Antunes, you see that it is nothing more than also a flexible ring characteristic, because the annulus develop fibrosis. And to differentiate these two from the very rigid is sometimes difficult, because you do have even a randomized clinical studies for that. How do you select, or how do you justify your selection for rigid ring?
We usually always use the flexible rings. We think that the flexible ring is anatomically better than the rigid rings, but it's only our meaning. It's not really sophisticated.
Right.
I think the problem is always with the sizing, and you can very individual perform with a flexible ring, and if you place the ring to less around the commissure, I think it really could be that after some years regurgitation can come again.
Right. Okay. Well, I won't like to touch too much questions now because, for example, regarding the pacemaker implantation, procedural related to which we are going to discuss panel discussion. Sorry. Yes. 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 A question. Yes, please.
Just to say that speaking about rigid rings or other techniques, that we have to have in mind that the tricuspid orifice is something completely far from being a fixed hole. I think that when you see the tricuspid are working as she showed us with the heart beating, you realize that the tricuspid hole is more sphincter than a hole. So if you place something rigid in a sphincter, it's difficult to believe that you are doing a lot of good. Okay? So what it will be the best thing? To get an elastic ring. But until we can get an elastic ring, I think that a well done, a carefully done technique with a suture, either one or maybe better my friend Antunes modification, it seems to me more physiologic than to place a rigid ring. Okay.
Well, that's an excellent comment. I think it's worth discussing this during our panel discussion. Shall we go back now to you, Roberto?
Yeah,
you are now on the right now. I would like to introduce you again because you were disconnected.
Yeah, sorry, I was disconnected. I don't know why. I don't know if they were Ukrainian or Russian blame.
Yeah, has been one of the legends in cardiac surgery. 50 years ago, you introduced this annuloplasty ring, which is the They are very young. They don't know. They know the name De Vega, but they don't know how this De Vega came about. So please tell us.
I mean, I was telling you the other day how strange it is to have keep alive a technique for 50 years, especially when it has been competing with all the medical industry of rings. That now there are more than 30 rings in the market for that. Okay, but as I told you the other day, it's even more difficult to keep alive the surgeon who described the technique. And fortunately,
You are still alive.
Still alive. I'm playing golf every day, except today, because I am with you. Okay. Look, at the time I described that, it was 50 years ago. And as my good friend Antoinette remarked, a surgeon, a lady surgeon, Nina Brownwell, was the first who said that we have to forget about tricuspid valve. Okay, that tricuspid valve, it didn't need to be repaired. So we follow her advice, and at that time, 85 or 90% of our surgical patients, they were rheumatic disease. Okay, and we didn't look at the tricuspid. We didn't take care of the tricuspid, and we saw that a lot of patients, they died either in the immediate post-op, or they did very bad afterwards. So I had been trained in England by Dr. Buller, that he used to repair the mitral valve doing a commissuroplasty. So we tried, and we did some of K repairs, and we never were happy with that, you know. So as we had quite a few, or more than quite a few, rheumatic tricuspid, we start replacing the valve with all sorts of devices, the Star Edwards, Bill, fasciolata, then heterograph that my good friend Alain Carpentier used to give me every time I went to Paris to visit him, and all those valves, they work very, very poorly. So once speaking to another, a very, very friend of mine, I mean, and who died, Dr. Cabrol, he was one of the more brilliant surgeons in France, who are speaking about the tricuspid. We went through this kind of things, and he told me about a technique that it was very complicated and that it was very difficult to perform, and of course it was difficult to regulate the size of the final result. So I thought on that, and I devised that, and as I told you the other day, first thing I tried was a pig heart in my kitchen. Afterwards, we tried it in dogs. At that time, we had a lot of dogs to experiment with them, and finally, I never convinced my boss. It was at that time very difficult, you know. I convinced, before convincing him, I convinced
Mario
Ionescu, another French, a German surgeon, and then we start doing it at home, and immediately we saw how different the result, both the immediate results and the long-term results, were with this plastic or with a replacement. And that was the story, you know. And I have to say that I never named my technique with my name. They were others, they did it, you know. Yeah. And that's all, you know, that's all. There were times, I have to say that, there were times that the medical industry, they used to do what doctors, we asked them to do. And unfortunately, now we are in a time that quite often doctors do what the medical industry asks them to do. You know, that makes the difference.
Thank you, Professor De Vega, for the secret behind your technique. The message, I think, sorry?
Sorry, because I think you wanted to ask me about this, the annuloplasty in children. And young,
yes.
Okay, look, I think that if you are going to do mitral surgery in young people, it will be very good, at least to fix the tricuspid annulus, because I always think in tricuspid reg that in like a vicious circle, that is a mild tricuspid reg produce mild right ventricle overwork, and that produce a bit of annular dilation. So, and this is a circle, a vicious circle, that you can only stop it by avoiding the tricuspid annuli to dilate. And you can do it very easily with a pair of sutures, and you cut the vicious circle, and probably this young guy, 25, 40, or 30 years afterwards, it will be more happy if you have done that than if you didn't.
Right.
And so about children, yes. I will tell you that I have just one case experience in a Iraqi boy that they sent to me, and he had just tricuspid incompetence, and I did a plastic, but I couldn't follow up him because he went back to Iraq. But 4 or 5 months ago, I received this paper from a Japanese surgeon, that it is published in Pediatric Cardiology, that it is called De Vega Tricuspid Annuloplasty for Pediatric Patients, Growth Potential of the Tricuspid Annulus. This is a lovely paper that everybody can read it, and they have very good results. Okay, I think that I used too much time. Okay.
Well, okay. Well, this is information which is difficult to get, and now we have it, and we have it. Thank you very much. But of course, the very important message, sorry, who is speaking?
Happy birthday to you.
Thank you. Who was that?
I am Norberto. But
right. Thank you. No.
Happy birthday, because you are very young.
Thank you.
The day after tomorrow, I will be 5 years older than you.
Yes. Thank you. Norberto, your message to the cardiovascular community, especially the young surgeons, is that you have to try some of your thoughts, your ideas in your kitchen.
Yeah.
That's very important. That's what I was also doing when I was doing homograph surgery. I always have 2 hearts in my refrigerator every week. So it's a very important message from your experience, from the secret behind your annuloplasty. But if you haven't tried it, you couldn't have introduced that clinically. And every, what you call the charity begins at home. It means every successful surgical initiative should start from your kitchen. So thank you very much. And I would like to continue a session by introducing Dr. Emily Falkosh. Is he connected? Or is gone?
I am. I'm here. Thank you,
Yes,
Professor.
Emily, thank you. I mean, for this reshuffling of time. We also, as surgical session, we always have to count that one surgery we're doing that and that. So we have to be flexible. And now you are there to welcome the cardiovascular community around the world on behalf of the CTSNet.
Thank you for that. It's personally a privilege to be here. Dr. and Professor Yankah and I have worked together on global efforts in the past, and you remain such a committed and constant presence in our circles, so thank you for that. And professionally, on behalf of CTSNet, we've always aimed to be a platform for bringing the cardiothoracic community closer together globally, whether it's through advocacy or information sharing, education, publication. But really, it really is about a connection, and we all have so much to share from our expertise and experience with each other, like we're doing here this morning or this afternoon. So it's a thrill to collaborate with the Pan-African Society of Cardiothoracic Surgeons, and an honor to be here representing CTSNet this morning. Thank you.
Well, thank you very much. Now that we are on the African line, we would now like to ask Professor Francis Smith to share with us the problems regarding cardiothoracic training surgery. And I hope this will more or less give us some more insight about what to do today and what to do tomorrow, and how can we reconcile the problems with the young and the old generation, and see how we can develop sustainability and resilience in cardiac surgical delivery in Africa. So Francis, the floor is for you. Your slide is already on. Are you okay, Francis?
I think he is muted.
Francis? Hello? Francis is muted? Yes, he's on.
Can you hear me now?
Yes, we can hear you now, right.
And can you see the slides?
Yes.
Okay, wonderful. Thanks very much. I'd like to sort of talk about the development of a multi-center integrated interdisciplinary simulation program, basically as an example of what could be possible in Africa and other low resource limited countries, and maybe sort of beyond that as well. Now, I think that it's well known that Africa has got 1.4 billion people, up to 1 billion in sub-Saharan Africa. The community is greatly underserved and units are underfunded. It's a limited resource environment with competing priorities and disease profiles between communicable versus non-communicable disease. There's certainly a lack of political will and a clear strategic objectives, sometimes confusing priorities within the public sector versus the private, versus a combination of the private and public sector. Medical tourism provides some challenges. There's certainly corruption, and we've also now lately faced 2 or 3 lost years as a result of COVID-19. The thing is what's going to happen to cardiac surgery programs in sub-Saharan Africa? And I think it is true, all of the above, and I think it's been listed for many years. But I think what remains is that this is not an if there's going to be cardiac surgical programs in Africa, but it's when, and units keep on opening. So what can we do? I'm not going to concentrate on anything but the training programs. Obviously, there's a role for advocacy and influence. We've got to create alternative, cost-effective service delivery models. And certainly we have to become part of the epidemiology community, accessing broader audiences in order to influence decision makers on the political sphere. For that, we need accurate data systems. And I think it's also important to start training multidisciplinary teams using available technology in expectation of future programs. To that extent, we've developed an integrated interdisciplinary simulation program in Bloemfontein, University of the Free State, and we believe that it's an essential addition to national and regional cardiothoracic surgical training and education programs. And I think this is also links to training programs in other countries. I think that if we look at our training philosophy here, this is not a simulation program, it's rather an education and learning program with training using some simulators as a holistic approach to cardiothoracic training. So firstly, I think that we have to look in any training program, and we specifically want to do it in this program, at human factors, as I think it's been clearly shown before that up to 67% of all mistakes made in operations are based on human factors. So I think that is part of our, that is a priority for us. And just to recap on the massive impact that the crew resource management and human factor management had on the safety of flying, I just want to show these statistics in aircraft crashes and deaths. And since the introduction of this system, there's been a massive reduce. I think there's a need to understand the risk and risk management, the Swiss cheese model, for example. And then I think that no one would disagree that we need to address some factors around communication, decision making, working as a team, the workload management, and situational awareness concerned in cardiac surgery. However, I think that the one thing that's really important is that if we believe, I think that a lot of us grew up in an era where cardiac surgery was to be performed by the specially gifted. And the question is that really true? And how do we train people within limited resource or limited case exposure systems? So what we're looking at is blended learning programs that's combined with purposeful practice, has been advocated by Anders Ericsson in his sort of well-known iceberg model. I think that we believe that training is an evolutionary process, and that automaticity through repetition and feedback loops develop over time. That eventually you will have pattern recognition, patience, and a long time of training is certainly the rule, with a 10-year rule of creativity in most disciplines being confirmed in a wide series of fields. And once you get to creative innovation and new skills, we really believe that you have achieved proficiency, which is the goal and the object of this training program. So if we look at it, what does it entail to look at education in cardiothoracic surgery? Possibly the first step would be, we plan to transfer a skill, but also a transfer of knowledge. And then there should be a process of facilitation of insight, the facilitation of the ability to execute correct decisions effectively, and finally, the facilitation of the ability to integrate all the variables of a clinical picture and make appropriate decisions. Now, if we look at an integrated interdisciplinary simulation model, that's something that we think we should aim at in our specific environment, and address each aspect of the individuals or groups of people involved in cardiac surgery, as the weakest link certainly produces a lot of complications. So the first thing is to look at virtual outpatients, of which ECHO programs forms a backbone. I think that Charles has done a lot of work in that respect. Then to present a non-technical skills for surgeons course really takes a day or two, and I think it's worthwhile that any program has a section on that, and that explains the importance of multidisciplinary approaches, team training, and CRM, and also a little bit of background about education, neuropsychology, and systems design and management in achieving goals. We have an allied health care professional training focus, which we haven't fully developed at the moment, but it's in development. And then we get to the basic surgical skills, dive bench, wet bench models that we're all familiar with, inclusive of more advanced tools like virtual reality simulation. We have a virtual cath lab to look at wire skills, and then a virtual OR with high fidelity cardiac beating heart model with cardiopulmonary bypass abilities and ICU management ability. Now, if we look at these systems, obviously all these subsections imply that the development of curriculum in order to address this in a holistic way. So how we see this and how we've done this in South Africa is that basically the University of the Free State forms the hub, and then the surgical theory, interdisciplinary through resource management or human factors courses, educational theory, and also the core theoretical knowledge can be done in the center where a registrar or trainee be stationed. And it only requires to come to our unit for high fidelity integrated simulation and multimodality assessment systems. Obviously, if this can be implemented in the country, it can also be implemented in regions across Africa. We look at a 2-year modular program. We start off with 3 days of introduction at the University of the Free State, looking at human factors and team dimensions, educational theory and practice, because we find that it's important to teach both the trainee and the trainers some principles about educational development. We believe that with the present setup of training and the minimally invasive route that general surgery is taken, that there is some sense in looking at basic cardiothoracic surgical skills program, and also to look at basic sciences amongst it would be flow dynamics, etc. And for the young trainee, and which needs to be assessed as appropriate. Then at home or at the local level, our program revolves around a principle that there's an introduction of any topic, doesn't matter what it is, with clear aims and objectives communicated to the candidate. We include a CRM component or a human factor component in every lecture, understand what the education goals are. We use a blended learning format, and the theory then obviously involves reference reading when video lectures as appropriate, and the theoretical assessment that needs to be passed before we progress to the practical side. So on the practical side, once again, once you've passed the theory, you're allowed to do the practice thing. There's a demonstration video with a simulation exercise with a clear evaluation system, can be recorded, and then with assessment and feedback. Now, what I want to show you is just a short video of 2.5 minutes or so video of what's happens at the center. I can indulge you to have a look at this. Basically a virtual reality system. It's also got tactile feel in the manipulation.
You don't see the video.
Can you see the video?
Oh, you don't see the video. Only music.
Can you not see the video?
No.
Okay.
Okay, fine. I'll
Shall we continue, Francis? Because the time is getting.
okay.
Yes. Can you conclude so that we discuss.
In order to look at this program, we've also developed an app that's based on a smartphone. It contains the course and training material and the individual data of the trainee, as well as the training material. It can be used to monitor and for quality control purposes. It provides the assessment and feedback, and can obviously provide a course for a source for research and development. And we believe that this program can make a contribution in the preparation for future units and to integrate teams in order to reduce risk and to provide a standard of training to different trainings in different settings. I just want to thank our co-workers and thanks very much for the opportunity, and from my side and our team here, also congratulations, Charles. Thanks very much.
Thank you, Francis, for this very, very important topic in Africa. And the training program is a very, very important topic. Well, we have this discussing this. I've been discussing this with you for the past 7 years about how to improve training, not only the training program, but the skill training programs. If those colleagues who sent for examination for board certification, some did only 10 open heart surgery, 15 open heart surgery, and they go and sit for board certification to be called cardiothoracic surgeons. And this actually is a worry to me. It's a very big concern. And that's why we have been discussing this with you, whether simulation training program can be integrated in the general cardiothoracic training program in Africa, at least in the sub-Saharan. And so far, we haven't gone so far because we haven't pushed more, up to the certain level. And I believe that it is the right time now, because my vision now is sustainability and resilience. It will come some days, some years to come, like Putin is doing, but Africa will be in a chaos or in a health crisis, so that nobody would like to go to Africa. So it means the Africans themselves have to do their own surgery, they have to do their own this and that. And we have to lay down certain fundamentals, program projects of how cardiac surgical training should be directed. And that's why I think simulation will play a very important role. If you have an idea, or you haven't operated more than 6 months, you go to the laboratory and try to do something to upgrade your skills. And this is very, very important. We take it, we are not taking it serious, but it's serious. Because a patient will come, you have never even done such an operation for the past 6 months, and you are going to do it. That's it. See? So I'm trying to organize in October, during the EACTS meeting, a workshop. I will discuss with you later on, Francis. I've invited even Emily, which she has accepted, thank you, so that we try and get some of our colleagues. I'm going to invite a lot of African colleagues to come and meet so that we can discuss in the future, at least some centers who are interested, who are not arrogant or self-conceited. We come together and develop plans. We are always there to help in developing these plans. So I think that is very important, and this will be a topic we are going to probably discuss also in the panel discussion. So thank you, Francis, for bringing this topic, and I will give over now the moderation to Manuel. Is he around to moderate now the panel discussion by inviting the invited discussants, Professor Abdel Malik, Professor Mokeles, Oguru, and Dr. Mazri Farid, so that you can then moderate their discussions. on what they are going to present. So, Manuel, thank you for taking over the moderation.
Well, thank you very much for that. Who is the other moderator? Where is he?
Sorry, Manuel, don't forget that you have also conducted some training program in Mozambique, which is also part of the training program, which you're also having some challenges. So try also to articulate your challenges during your training program with the Mozambican colleagues, so that we can learn from you two as well.
Well, that was not part of the initial discussion, but for the others to know.
Training is part of Francis' lecture, Cardiothoracic training program. Yeah.
That's right. Okay.
Okay.
That's right. Now, early in the 2000, in fact, before we turned the century, we were asked by the colleagues in Paris and in London to cooperate in a project which meant to initiate a open art program in Mozambique, in Maputo, Mozambique. And we created our art institute from an old hospital, military hospital from the times of Portugal, and build a unit which had some 20 beds and 2 operating rooms. And we started making missions, annual missions, 4 or 5 different people, the Jacob's unit, the Paris unit, also from Switzerland, and ourselves. Basically, we were the 4 coming there. And since then, I have been there every year with my team, and with the exception of the last 2 years because of the pandemic. We are now planning to restart this year, the mission. But that's not what I wanted to do, because there are missions everywhere, people going to help and do surgeries in many parts of the world. What I think that it is more important is that it has happened also in Africa in some other cases, but not all that frequent and not with the duration and the success I think we had. That is to create a local team which is now able to perform open heart surgery in children and adults, mainly in rheumatic patients also, but 2 local surgeons, and there is another one who has gone on to another hospital doing the same thing, and they are now completely independent in doing that. So our missions now go there to help them in the cases they thought that were a little bit more difficult to do. And when I go there, what we do, what I and my team do mainly is mitral valve surgery, mitral valve repairs, mostly. We have been very successful. It's different when you work with these people. Sometimes we operate on 6 and 7 and 8-year-old children with acute rheumatic fever. You need to have severe tricuspid mitral regurgitation. It's very difficult to decide what we're going to do, because if you replace those valves, you cannot replace with a mechanical valve, because they don't know how to take anticoagulation when they go back to their parts of the country, to their villages. They stop doing that, and as you know, biopsies fail very early with that. So we have this philosophy that even if we can only guarantee a 5-year freedom from a prosthesis is good. So we go as far as possible to do repairs. And although we thought that it would be a very short-term fact, is that we have patients treated this way and are there still 20 years later with their mitral valve, sometimes leaking a little bit, sometimes a little bit not, but still working. So your approach to surgery has to be different where you are and where you are treating the patients. You know, it's obviously in Africa is different. Of course, we just had Francis Smith, and I say hello to him. I hope to see you soon in person again. Are you going to Boston?
Yes, I am. Yeah.
Well, then we will meet there. Of course, South Africa is a different African country. I used to say that it's not, is in Africa, but it's not an African country because it's different in regards to cardiac surgery. But there are some areas still there. When I worked in Johannesburg, and Francis in Bloemfontein has the same, we had the same typical African patients that had the same type of disease and raised the same problems when we had to treat them.
Emmanuel, can we conclude now?
I was concluded.
Oh, because our time is running.
You raised the question, so that's
we have 1, 2, 3, 4.
I would like to hear what the others have to say about that. People in different parts of Africa, what they have to say about this.
Yes, yes.
Charles, can I just say something? I just want.
Shall we? Otherwise, we can't go on. We have to allow our African colleagues now to also to start their program to give their presentation.
Because
sorry, we can discuss that later on, Francis. Now we call upon Professor Abdel Malik from RGS to give precisely, within 5 minutes, his experience on rheumatic mitral valve surgery with concomitant tricuspid valve repair.
Okay, thank you, Charles. I will share with you.
Without slides, just free speech, no slides.
I'll give you a very short.
Please, no slides. We are going to waste too much time.
Okay.
Just give us the figures. We need your figures to discuss. Just give me how many patients have you operated, how severe is the tricuspid regurg, and how is the result?
Charles, I will share with you a study we done in Constantine 3 years ago about mitral rheumatic disease with tricuspid mild and moderate regurg. We compared the two groups of patients with the sinus rhythm and atrial fibrillation, and there are similarities of the two. The results 12 months after the operative replacement of the mitral valve, we see degradation of the status of the fibrillation patients, degradation of the EF, the dilatation of the right atrium and left ventricle, and significant tricuspid regurg in these patients. So when we search the factor risk of aggravation of the TR in multivariate analysis, we found the female sex, and most importantly, the atrial fibrillation. And the risk was 12 odds ratio, 12 times more in the group of atrial fibrillation. So in this study, we compared with others. It seems that the atrial fibrillation is a risk factor of late progression of tricuspid regurg after mitral valve surgery. And so when we see this study published in 2008, the maze technique associated with the tricuspid annuloplasty give the most best results at 12 years. So we conclude that in these patients with AF, we might perhaps think to do preventive annuloplasty or with or without maze procedure. I want to share with you this study we published in 2015 about use of a flexible ring, a homemade ring, a strip of PTFE in 72 patients. We used in 32 patients of these 72 patients, and it gave good results. So in countries like us, when have not always the opportunity to get rings, we can make it home. Thanks.
How's your hospital mortality?
Mortality in
Hospital, 30-day mortality.
In
30-day mortality hospital.
6%.
Right, excellent. Thank you. Well, the next, Dr. Masuri.
Yes, good evening. I'm sorry, I cough a cold,
No
so
problem.
my voice is very strange. So I hope to share slide with you.
No slide, please.
No slide.
Your information, your data. How many patients have you operated in your hospital with mild, moderate tricuspid surgery, and
mild
how?
and moderate. Yeah, we have from in 10 years we have 97 patients underwent tricuspid repair concomitant with another surgical procedure. In 58 cases, there was it was mitral lesions and isolated mitral lesions, and the other it was aorta lesions and atrial septal defect. The average age was 43 years, and the range between 16 and 70 years. Sex ratio was female predominance, and tricuspid regurgitation was moderate in 55% of patients, and significant in the 38%. The choice of the tricuspid repair techniques was left to the surgeons. It's an important notion, and the follow-up was 76 mouse, range 9 and 120 mouse. In our results, there are 76% of the patients had an equal or less than grade 1 tricuspid regurgitation, and 10% have grade 2 regurgitation, one patient grade 3. The techniques, the different techniques were done. The De Vega is done in 48%, and the ring, flexible ring, in 33%, and the other the K techniques in 11%, and 5% have combined techniques because rheumatic lesions. We have observed the right ventricular dilatation is involvement from 30 to 60%. And what can I say, that our population was younger than the European series with the same female predominance. There was no significant difference in terms of late and overall mortality between the De Vega techniques and the other techniques, and there was no significant difference in cardiac events and worsening of tricuspid regurgitation between the De Vega and the other techniques. The only significant difference was the duration of cardiopulmonary bypass and aortic clumping shorter in the De Vega. So, in conclusion, the De Vega annuloplasty technique is fast, inexpensive, without foreign material, and has the same results as other longer and more expensive techniques. Thank you.
Thank you. Welcome. I would like to call Professor Mokeles from Tunis to share his experience with us.
Okay. Do you hear me?
Yes.
Okay. Greetings. Thanks for all the experts and my master's present here today. I'm very honored to be here. Happy birthday again for Dr. Yankah. So I will briefly speak about our experience in Tunisia. I think our department is representative of what is done in the country. Rheumatic fever is still endemic. 40% do carditis, and it's mainly mitral stenosis. In 2000, we performed a review of patients we operated between 95 and 2000 for isolated mitral valve stenosis, and at the time we performed isolated mitral valve replacement. 20% came back after 5 years for severe tricuspid regurgitation. It was a shock for us, and there was a big switch in management strategy. Since then, since 2000, we performed 30-35 cases of mitral stenosis a year. 20% have severe tricuspid regurgitation, and 50% have mild to moderate tricuspid regurgitation. The main age is 45 years old, three females to 1 male. Our main concern is that 70% of those patients 70% of those patients came to surgery after percutaneous mitral commissurotomy, 1 or more procedures. Those patients are lost to follow-up after the percutaneous procedure. They neglect symptoms. They come back after a large time span. So 30% have dysfunction of right ventricular, 70% have arrhythmia, and the mean pulmonary pressure is 60. So we deal with advanced mitral valve stenosis, and tricuspid regurgitation is very frequent. So we do mitral valve replacement. No repairs are attempted. We lack the techniques, and the mitral valve pathology is very severe, so we do not attempt repairs. Tricuspid annuloplasty with semi-rigid ring is performed. We follow occidental recommendations, so mild, so severe regurgitation, or mild to moderate with annular dilatation above 40. But we are very aggressive. Even if we fall below those recommendations, we tend to do prophylactic annuloplasty. Honestly, we stopped performing De Vega annuloplasty because we performed an evaluation on long terms, and we saw that 30% came back with severe tricuspid regurgitation. But our indication type of regurgitation and the technique at the time were very, very questionable. Nonetheless, we think that ring annuloplasty is more easily taught for younger, less experienced surgeons, and more easily reproduced, but it's very personal opinion. We think that the technique is very straightforward for the annuloplasty ring. It's safe, and it shouldn't dissuade us from performing preventive surgery. So we are very aggressive. Nonetheless, we have 2% atrioventricular block, and we switched from 20% relapse of tricuspid regurgitation to maybe 1 patient over 2 years that's coming back with severe tricuspid regurg. To conclude, I think that the main problem is that in Africa, the main problem is more the indication than the technique, and we should consider prophylactic tricuspid annuloplasty, stabilizing annuloplasty with left valve disease. I mentioned a very important thing that Professor Antunes said, is that those patients are poor, they have poor access to healthcare, and there is no second chance. And even if there's a second chance, they come to surgery with right ventricular dysfunction. We know that the mortality is high, and we know that the long term is bad. So it's important to adapt the recommendation and guidelines to our reality, to have our own guidelines, and we should be maybe a bit aggressive with tricuspid regurgitations to preserve the future of our patients. Thank you.
Thank you very much, Professor Mokales, for this excellent experience from Tunisia. And our last discussant is Dr. Gilbert Oburu from the University of Nairobi. Please share your experience with us so that we know what your challenges at your end.
You have to switch on your microphone, Dr. Oburu. Yes.
Okay. Yeah. I'm back on. Yeah. Thank you very much, Professor, for giving me an opportunity to highlight a few issues from Kenya. Not only Kenyatta National Hospital, but other hospitals around. Now, yes, we do both mitral valve replacement and mitral valve repair. And we have had issues of concomitant tricuspid valve repair in managing our rheumatic mitral valve surgery patients. Okay, I did a short biodata of the kind of patients that we encounter. I'm presenting a situation of about 36 patients, 17 male, 19 female, age ranging between 13 and 77 years, with a mean age of 44.45 years. Of these patients, this is actually data of recent from 2020 to 2021, despite the COVID. So basically, that means that we have a rather good number of patients requiring surgery. So the total mitral valve replacement was in 36 patients. Of these patients, 23 only had mitral valve replacement. 13 required concomitant tricuspid valve repair. The tricuspid valve was repaired mainly via modified devastating annuloplasty. In two patients, we actually used ring annuloplasty. Of these, we lost one patient within 30 days after surgery, and the patient, apart from having rheumatic heart disease, also presented with infective endocarditis. And again, from 2017 to 2019, we managed 21 patients who required mitral valve repair. In this case, actually, 8 were male and 13 were female. And the age range, this is quite significant, was much lower, ranging from 3 to 25 years, with a mean age of 12.52. Of these patients, all the 21 of them had, yes, mitral valve repair, and 3 only required concomitant tricuspid valve annuloplasty. Mitral valve repair, 2 of these patients also, apart from mitral valve repair, also required a MACE procedure. In this case, one post-mitral valve repair surgery patient with no tricuspid valve intervention succumbed within 30 days of surgery. So in short, we are concluding that our patient population still remains much younger compared to general worldwide population. And our patients who we subjected to mitral valve repair were still much younger compared to the patients who got mitral valve replacement or the cohort. Comparatively, more mitral valve replacement patients had tricuspid repair, 13 out of 36, which is 36%, compared to the patients who underwent mitral valve repair, with only 3 out of 21, 14%, also receiving tricuspid valve annuloplasty. And none of our patients came back for a redo tricuspid valve repair. However, the patient, the 25-year-old patient who had mitral valve repair was actually a redo. Thank you very much.
Thank you, Dr. Oburu, for this interesting experience from Kenya, Nairobi. And I would now like to hand over the panel discussion to Manuel. Now we have enough data for discussion. And I welcome Carlos Mestres, which I see him over there. Carlos, thank you for attending, and I'm sure you will help Manuel to in the discussion. So I hand over the panel discussion to you to the end. I'm not, yeah.
Hello, Carlos. It's nice to see you again. I think you should start making your comments because I already have spoken quite a lot about it, about what we had. I was just saying it's different. The panorama is different in different countries of Africa, but you have experience of that. You have been in several places in the world. It's not just Africa. Our discussion here has been basically around, I think we all now agree that you need to treat the tricuspid regurgitation when it is at least moderate. But what to do, especially having in mind costs and techniques and the age of the patients and the eventual need for reoperations in the future. What are your feelings about this?
Well, thank you. I'm sorry for being late. I was stuck in a traffic jam, and now from Singapore, so that's why I could not make it on time anyway. So I think, as you said, there is enough information now to understand that we have to do tricuspid repair. I think Bettina Fambula said something about that, and I agree. There is a bunch of evidence now that we have not used on a regular basis tricuspid repair in the cases of mitral valve disease for many years. But I think that, as you said, one of the problems is to understand where we are and where we practice in terms of type of technique and approach. I think these brief data from Nairobi are also important because in places where you need to take care of, for instance, coast, these things are becoming important. As you know, my latest practice was in one of the richest countries in the world, which is Switzerland, which all these pros and cons that they have. But in those places where money is not an issue, you can do whatever you want. If you work in other places, and I think we have a very good overview of different practices across Africa, you need to understand where you are, and the ability to do things and to follow the patients and get significant information is probably different from in Europe or in South America or in other places. But I think that, generally speaking, I think that we have tremendous amount of data now to confirm that tricuspid valve repair at the time of mitral valve surgery is a kind of must, and then we need to be probably more liberal than sticking to specific old-fashioned indications in terms of TAPSI and how the annular dimension are. I mean, I was taught by my boss when I was very young, Dr. Marcos Murtra, who used to be EX president many years ago, and we were at that time quite aggressive with tricuspid annuloplasty. It was almost 40 years ago. But I think that again, longitudinal analysis of series from many places in the world, it's very clear that we need to do something, and the value of adding tricuspid annuloplasty in mitral valve surgery pays off years later. I remember, probably is the experience here, that many of the patients that we saw with tricuspid regurgitation over time, they came very late for different reasons. They were in much more advanced New York Heart Association functional class. And above all, there was actually right ventricular failure, which I think is one of the most important factors for mortality. And this was the discussion. I mean, these people that they need reoperation because of tricuspid regurgitation, they have much more morbidity, much more mortality, and so on. So this is what is my feeling after many years of reading contributions and our own experience as well. So that's the way I think that.
Well, the question in here is what type of annuloplasty should we use? Cost is a word that I'm not sure that I have heard in here, and it is probably important in some countries of Africa. I wanted to know if one of our colleagues from the African countries who have just presented their results have any say about the question of costs. Of course, the rigid ring is more expensive than the flexible ring, but both are expensive. Sutures are much cheaper because in fact, it's just one suture piece that you go and come back. Anyone has anything to say about that? Our colleague from Kenya, Obru.
From Algiers. From Algiers.
Yes. Okay.
Algiers.
Please go.
Okay.
Yeah.
Our experience with the annuloplasty, we began with the Vega. All surgeons began with the Vega technique. And
modified the Vega?
No, the Vega, not modified the Vega. The Vega. We began
the
with
original
the Vega.
Right. Okay.
Then and key technique, and then when the country have budget, sufficient budget, we got the rings, and then we have crisis of the 2014 when one petrol dropped, and Algeria is a petroleum country, so we have not enough money. Yes, and then we reuse the Vega, the original. We reuse other techniques like the PTFE strips. We use pericardium for annuloplasty, and we use modified techniques, enlargement of the anterior leaflet, etc. So we use what we got now, and it is depending of the availability of rings or not. If it is available, we use it, and we use more frequently the rings, not rigid rings. Yeah, because it's less expensive. But even these rings are not available always. So we use what we got.
Yes, someone else? Dr. Oburu, I had asked you. Microphone, please. Yes. Coming.
Yeah, okay. We mainly use modified Vega annuloplasty, first and foremost because of the cost implications of ring annuloplasty, and second, Our results so far from what we have seen are not bad. Our patients do rather well, even in the long term. So given the economic situation and the kind of results that we have, we think probably we are still going to do. And occasionally when we have patients who can afford an annuloplasty ring, we will put an annuloplasty ring for them. Thank you.
But that creates a medical problem. Problems you can afford, you use a ring, and the others you don't use. Is that a problem? You think that you are giving an inferior treatment to those who cannot afford a ring? Or are you very happy that you're getting similar results or very acceptable results?
Okay, yeah, we have not, so to speak, done a large enough study comparing the Vega annuloplasty and semi-rigid ring annuloplasty, though the data that is there kind of tend to support a semi-rigid ring annuloplasty compared to the Vega. But I think when you are confronted with a patient who has the possibility of affording a ring, then probably we can do a ring for the patient. Thank you.
Dr. Farid?
Yeah. We are very satisfied with the Vega, modified the Vega, because we use the modified the Vega in most often patients who have tricuspid regurgitation grade 2 or 3, but in the tricuspid regurgitation grade 4, we prefer flexible or rigid rings. Well, thank you.
Dr. Lan?
Our situation is a little bit funny because my seniors did the Vega all the time. So then there was the rings, and with the pressure of the pharmaceuticals, all my seniors did the rings. So my generation of surgeons learned only to do the rings. Now we have problem with economics, and there are no sufficient rings. So we have to learn again how to do the Vega, but it's a little bit challenging, I think, and even the seniors left it a bit. So we have to learn it again. So I would be very pleased to come and learn it with you, if it's possible.
Well, maybe I could address this question to Dr. Van Muller, because you said that you use preferentially the flexible rings. You're talking about which type of ring? Is that a band? Can you consider it a band? Because if you saw that picture that I showed of the patient who had the platelets in the modified Vega with platelets, you can use Teflon or can use pericardium, you can use a pericardial strip. The result is the same. It gets incorporated, and with time it becomes really a flexible ring. My view is that if you do that, you have to involve, as you insisted as well, to come up to the septal well beyond the posterior septal commissure, you know, in order to give that degree of constriction in the ring. What are your feelings about that? Because of course you're now not for the rigid rings, you're more for the soft.
My thought is that the modified Vega is nearly the same than the flexible ring, but the length of the flexible ring is defined. If I use to perform mitral valve repair with a degenerative mitral regurgitation, then I have anterior leaflet perhaps 32 millimeters. And in my opinion, it's often the best to perform the tricuspid valve also with a 32, or if you have a 28 mitral, you have a 28 tricuspid. It's nearly the same. And the flexible ring has a defined length. I think that's my problem. If I would perform a modified De Vega, I wouldn't know how much have I how small
you have, is it?
Yes, yes. How do you do it that you know that's the current, that's the best form or the best size of the tricuspid annulus?
There is no doubt that if you put in a rigid ring or even a flexible ring, you choose one of the sizes that come in the make. It's more standardized. You know, with what I have done for many years is that I use only two sizes, the Vega annuloplasty. I put a agar dilator in the tricuspid before doing the final tie, and this 24 for a big person, and this is 23 for a small, 22 very small person. And with that is quite a degree of constriction. Actually, I would like Dr. De Vega to tell me what do you used to do with the De Vega procedure to make sure that you had the correct size? What was your way to assess the final size of the annuloplasty?
I mean, if I have 2 minutes, first, I always place the sutures before doing anything in the mitral. Otherwise, once you replace, for instance, the mitral valve, the placement of the suture, especially in the posterior, anterior septal commissure, is going to be difficult. So I place the suture and I don't tie them. Then I go to the mitral and I do whatever it needs to be done, either a replacement or a repair. And then once the left atrium is closed, we open the aorta and the heart either start fibrillating or beating, and with the heart full, and that's the same beating or fibrillated, then you can see how the annulus is not the same as when you have the aortic clamp in place. Then we start tying the suture in one commissure in the other one, and we are flushing saline there inside, and we see how much we have to go. You know, probably we don't tie. I do remember, because you are not as old as me, but nearly, that when I said that we place 2 fingers inside the tricuspid, no, that was too much. You know, now having the heart either beating or fibrillating, we tie liter by liter, and we tie at least as possible, you know, because we really think that the tricuspid annulus, it has to contract and to remain flexible after the repair.
Okay. Charles, do you want to come on here as a panelist?
We missed one talk. Emily Farkas, who has also been doing a lot of surgery in West Africa, and we'd like to hear from her experience in rheumatic mitral or tricuspid, concomitant tricuspid repair in your experience in Africa.
Excuse me, may I may I ask just a small little question?
After Emily. After. Yes, please, Emily, can you go on?
Thank you, Prof. I don't need to expound on much because my experience has been similar to that provided by our colleagues. And I think it's mainly limited by the resources that we have available. It is interesting to hear the strategy that Dr. De Vega has utilized for years, as well as the Hagar dilators have usually been the way that we've tried to standardize our sizing of the tricuspid De Vega procedure in the countries where we operated. I actually would just like to ask the question of the crowd, because we're talking about very complex biventricular pathology here. And I think we all know that in any country, that right heart failure has been the Achilles heel, really, of cardiac surgery, that we don't have a lot of good adjuncts to protect or rescue the right heart, even with the best operations. And so I'm curious to hear amongst the panel if there are certain techniques or adjuncts that they utilize to take care of the right heart in these operations.
Yes, Dr. Buzit.
When we have, in our country, we have not circulatory assist. So patients with low EF, right or left ejection fraction, have a bad and worse outcome. So we use heart beating mitral surgery when you have no aortic regurg more than one grade. So when we have patients with the history of right heart failure and even with the conservative left ventricular function, we do mitral valve surgery heart beating and tricuspid valve heart beating too. And so we avoid to have ischemia and cross clamping, and we have best results with these techniques.
Okay, Dr. De Vega, you wanted to say something?
Yes. Yes.
We're reaching the time, we're reaching the limit.
Listening to those lovely African surgeons, it remind me what we did 30, 40 years ago when we had most of our patients, they were rheumatic patients. In our experience of those rheumatic patients, more than 50%, they were just mitral stenosis, more frequently in ladies. And we had such a good experience with closed mitral valvotomy that we did thousands of closed mitral valvotomies, and I still have patients operated of tight mitral stenosis living a good life after 30, 40 years. My question is, there is anybody there in the panel that it thinks that closed mitral valvotomy, it has a place in places where rheumatic valvular disease is so frequent?
The problem is the challenges among the training and the trainers. The trainers don't have experience in this technology or this practice, and so it makes it difficult for them even to advocate among their trainees. We are trying to run a training program, workshops, but the ECHO was not very receptive because everyone wants to do open heart surgery, and that's a big problem. See, everybody wants to do open heart surgery. I believe I've done a lot of research. About 10 to 12% of the rheumatic mitral disease are stenotic, 10 to 12 now. Formerly, as you are saying, it was over 50%. Now, because of antibiotics, penicillin prophylaxis, and so on, the incidence of rheumatic valve disease is decreasing, but still 10 to 12% of patients, the population with mitral stenosis can be treated. Children usually, because my first mitral stenosis I did was in Liberia in a 14-year-old girl with a digital fracture. So it is possible, but it is not sexy enough for many surgeons. That's a big problem. That is a big major problem. I've been trying to campaign for the last 2-3 years. There's no support. So I've given it up. Unless they see themselves, that they see children, school children, adolescents with mitral stenosis run around and they collapse, they have atrial fibrillation, they have strokes and they die. Instead of this preventive surgery, nothing is happening. So it is difficult to convince, and we hope probably it will work next year. Now, any question, any comments? Yes, Manuel, have any comments? Or Francis?
I'd just like to invite everyone. We have a Robert Freiter the Cardiovascular Center Celebration Day, to which I invited you as well. There is a simulation session that afternoon, which you're most welcome to attend. It's a hybrid conference, and then people can have a more detailed look at the training and simulation program. So I think that the important point is that we do not want to say that we run a simulation program. I think we run a training and simulation program, which is different.
Yeah.
But everyone's welcome. I can circulate it, whatever. I've given my email address on the comments box in the comments. So if anyone's interested, you're welcome to phone me, and you're welcome to join. Thanks very much.
You can send it to the PASCaTS website too as well.
Thanks very much.
Well, thank you very much, all of you, for the patience, for your time to get this webinar go through till 5:30 p.m. And I would like to just summarize a little, just a few. For the first part, I think, so far as the cardiothoracic surgery training program, is how to amalgamate the training programs with the professionals so that we can give more advice to the healthcare authorities to improve the cardiac surgical program. And I believe also that this simulation program is very important to bridge the gap among surgeons who have the low volume centers, so that they can still keep on their skills in case they have some challenges. And the second message, I think, is about this concomitant tricuspid annuloplasty and mitral valve surgery, which I think has to be taken seriously, because we now know from data, experience, clinical work, that untreated mild to moderate tricuspid regurg will worsen with time, even up to about 10 years, as data also say. And as we also discussed, modified de Vega annuloplasty, flexible ring annuloplasty are things that one has to look into, especially so far as those in the low-income countries are concerned, to consider which of these techniques might be suitable and also cost-effective for you to do more surgery. The most important that you shouldn't refuse any patient because you are used to ring annuloplasty and you can't do de Vega annuloplasty. DeVega suture annuloplasty can be practiced. Get 2 hearts always in your kitchen and practice how to do DeVega suture annuloplasty. See, so that you can always provide this technique to your patient who can afford rigid or commercially made annuloplasty. Very, very important. And lastly, we are going to organize in October during the EACTS meeting 2 workshops, one in collaboration with the EACTS in Ireland, and the other one is going to be an additional workshop, meet the senior experts and the legends in cardiac surgery. We would like to also introduce the young generation have to meet more and more of the experts and the legends, like you've met today, DeVega, how he went around with his annuloplasty. In October, we're going to meet more and more senior experts like Antonis, Carlos Mestres, all will be there to share their long-standing clinical experience so that you can also improve yourself. So thank you very much for coming to have this webinar successful, and I wish you all the best, and we meet next time. Thank you.
Thank you.